Hello, my name is Molly Jain and I'm an internal medicine resident with Parkview Health. I'm here to present my poster along with my mentors Dr. Joshi and Dr. Lubrin, and my case is on incidental anisocoria and acute renal failure, a surprising revelation of multiple myeloma. So for the background, multiple myeloma often manifests with non-specific symptoms complicating the early diagnosis. This case demonstrates the diagnostic challenges posed by its unusual symptoms such as anemia and renal failure. It highlights how an incidental anisocoria eventually led to the detection of this plasma cell malignancy. So moving on to the case. A 65-year-old male with history of morbid obesity, coronary artery disease and recent right femur fracture status post open reduction internal fixation presented with acute urinary retention and anacerca. On examination, he was in acute respiratory distress, requiring 5 liters of oxygen by nasal cannula. Due to his body habitus, renal ultrasound was inconclusive for hydronephrosis. Due to progressive hypotension and fever, he was started on broad-spectrum antibiotics including linezolid and cefepime, as well as fluid resuscitation and vasopressor. With patients worsening renal failure, continuous renal replacement treatment was initiated in the ICU. On day 3 of admission, he was also found to have left pupil larger than right, prompting a CT head. So, in terms of the initial labs and imaging, for the initial labs, BUN was about 48, which was really elevated. Creatinine was found to be 2.51. His baseline creatinine was 0.7, so really high from the baseline. Hemoglobin was 9.1 and MCV was 93.5. In terms of the imaging, CT head and sinus revealed 1.3 times 1.2 times 1.5 centimeters hypoattenuating lesion within the inferior aspect of the left sphenoid sinus. And another imaging of the CT head showed multiple regions of sub-centimeter lucency within the calvarium. Those were the pertinent imaging, which actually increased the suspicion of having a differential diagnosis of multiple myeloma. Other than that, bone marrow core biopsy was done, and that revealed results of hypercellular bone marrow with tri-lineage hematopoiesis and increased marrow plasma cells 44% by cell count, which was consistent with plasma cell neoplasm. Along with that, the flow cytometry and immunofixation results were very much consistent with monoclonal kappa gammopathy. In terms of the clinical course and outcome, patient was promptly started on inpatient chemotherapy with dexamethasone, cyclophosphamide, bortezomib, and daratumumab. Following initial improvement, patient developed Enterococcus faecium bacteremia and C. diff infection, along with hemorrhagic shock due to intra-abdominal hematoma. Due to worsening clinical status, patient's family actually opted for hospice care. In terms of the discussion of this case, patient's initial symptoms indicated renal and infectious causes, which were further complicated by comorbidities that concealed the multiple myeloma. Anisocoria or unequal pupil size is caused by neurological and ocular disorders. Though not directly linked to multiple myeloma, the disease may cause ocular problems by paraneoplastic and hyperviscosity syndromes. The patient's abnormal ocular examination led to incidental finding of lucent calvarial lesions, which ultimately revealed the etiology of his renal failure and likely femur fracture. This highlights the significance of comprehensive physical examination and broad differential diagnosis in challenging cases. And here are my references. Thank you so much for listening to my presentation.